Hi, everyone, and welcome to Texas. Happy February, everyone, the month of love. And we're here on this, we're here this month to tell all the people how much we love them. I love this mastermind group. I flew all the way in here from Texas, and from Arizona to Texas, and I'm just so excited to be here. This is our first out of state mastermind. We want to start visiting states where our members and listeners are located. So, New York, California, Florida are some of the states that we are looking to continue to visit. We welcome your feedback and your request to host us in your home state. We had 46 companies registered for our webinar today, and we continue to grow our membership and participation with every monthly meeting. The mastermind was created for you, so please join, participate, give us your feedback. We started this Facebook group, search for Medical Billing Company Owner Mastermind, request to join. You'll have access to upcoming conference information, the masterminds, and a chance to further network with fellow billing company owners. Our next mastermind is next month, March 14. Tim Cardew from Practice Max will be talking to us about payer contracting as a revenue generator, and there'll be a link to sign up in an email that you'll receive later today. For those of you that are new on the call, my name is Connie Gluck. I'm the CEO of 4D Global. We help billing companies grow their business profitably by leveraging our highly skilled medical billing and coding team in India. Please reach out to me if you want to know more about what we do and how we can help. I am excited to introduce our newest member of the 4D Global leadership team, Olivia Miller. Olivia has graciously agreed to reach out to all of you in the upcoming days to obtain your opinions, topics of interest, so that we can plan our 2019 meetings. Olivia, are you with us? Are you able to?
I am.
Oh, there you are.
Can you
Okay.
hear me?
Yeah, so please introduce yourself to everybody.
Hi, my name is Olivia Miller. I used to be a co-owner of Delphi Management Services, so I was sitting on the other side of this call up until about 3 months ago. And when I called Hani to let her know that I had sold my company, she said, "Come work with me." I've been working with Hani for about 2 years now. She was my outsourcing company. So I obviously am a big advocate of 4D Global. And I'm really excited about this new position and to be talking to all of you guys. So like Hani said, I will be reaching out to everybody afterwards because I'm trying to put together a mastermind schedule for the year and get an idea of what the challenges we're all facing this year and what 2019 is going to hold for us.
Awesome. Okay, thank you, Olivia. So 2019 has been off to a great start. I went to visit my team in India 2 weeks ago. We had an awesome time. I've had many conversations with many of you mastermind attendees and listening to some of the biggest issues billing companies face, and marketing keeps coming up over and over again. And so the small business owner we've been hearing is having a hard time hiring a full-time salesperson, but still wants to do something related to marketing, and they don't have the budget to do that. So we launched 4D Medical Marketing, which is a marketing firm specializing in specifically healthcare marketing. We make marketing affordable to the small business owner. If getting more physician clients is something you're interested in learning more about, please reach out to myself or Olivia after the call. Also, Kevin's going to be in New Orleans next week at the MBEC conference. I have Dave Giachello joining us at the end of the call. He'll tell us a little bit about what to expect at that conference. And without further ado, I'm going to introduce you to our presenter, Kevin, who's sitting right next to me right here. Kevin Ewald is from RadMax. He is a billing company owner specializing in radiation oncology billing. Kevin will cover two of the foremost challenges billers face today: authorization and credentialing issues. I met Kevin a couple months ago. He was at a conference in Arizona. He was staying at a hotel right across the street from my house. We got together, we started talking, and I asked him if there was anything relevant he could share with the group. And he said, yeah, I do actually. And we're here now. So I'm going to give it over to Kevin, and we will get started here. Okay, Kevin, you're up. Hold on. 1 second, change presenter. Okay.
Well, good morning. Well, good morning. It's Dallas, Texas, a little bit chilly today. Actually, nice, very nice. And I have a billing company located in Tyler, Texas. We're about 2 hours east of here. We do mostly radiation oncology. We kind of got into this many years ago. I used to run cancer centers, and I started doing the billing in those cancer centers and hospitals. And eventually, I was a programmer, and I used to do programming for radiation oncology specific software. And one of my partners, Craig Lawton, who designed the software program for quality control with radiation, we started this company back in 2004. It's been an interesting road, as all you owners of billing companies know. It just keeps getting more and more complicated. And when Connie and I talked before, Cheney and I talked before, we were discussing some of the issues that billing companies are coming across more and more these days. And one of them that came up was, of course, authorization issues. A lot of you may not have control over authorizations because you're billing for a client. The client is in their office somewhere in a hospital or a facility, and they're doing their own authorizations. And of course, credentialing was another issue too, which is kind of it's a term for provider enrollment on our side. We used to do provider enrollment for all our clients back in the day when we first started because it was very easy. It was basically just a couple pieces of paper and it was done. But if any of you are doing that now, you know that's not the same. And so we're going to talk about some of the issues with credentialing and authorizations. They kind of go together. You know, with managed care, the increase in managed care, you all know your providers have to be credentialed with those payers in order to get paid. Goals. A couple of goals we have right now is to increase, with the increase in managed care in recent years, we're going to explore the issues we just talked about before in getting paid. And then we're going to talk about authorization, some of the solutions that we've come up with as a company, and some of the things we do to ID some of those issues. As many of you, or some of you may be aware, I've been around this business a long time. I started in California back in the 80s. I worked for St. John's Hospital in Santa Monica and UCLA in Los Angeles, and I kind of worked my way up the ladder and eventually wound up in Dallas, where I started working for Texas Oncology, and then out in Tyler for East Texas Medical Center. But you know, back in the day, 80-20 plans were pretty popular. And of course, you know, we had HMOs back then, started in California. But if you didn't get paid, you usually had out-of-network benefits. Today, that's changing. Even in the traditional Medicare area, it's turning to Advantage Care plans now. As a company that does a lot of radiation oncology billing, mostly, probably 90% of our business, we would see in about 5 or 6 years ago, about 50% was traditional Medicare, maybe 5% traditional Medicaid, and that's not the case anymore. You know, we're seeing maybe 20% traditional Medicare, and the rest, maybe 20-25%, is Advantage Care plans. And you know, we know that in places like Los Angeles, we have clients that the traditional Medicare is pretty much gone. For hospitals, so I just did a talk yesterday. That's a hospital organization, mainly down in Houston. And, you know, hospitals typically do not, they don't do provider enrollment unless they employ the physician. Their enrollment is considered, you know, the primary source. So don't get confused with that. For billing companies, if you have physicians which you're billing for, you know, we're talking about enrolling the physician in different payers to get paid. And this is not to be confused with contracting. Contracting is a whole different ball of wax. Contracting is for dealing with insurance companies and negotiating fees to be paid. As a billing service, Shane and I were interested, you know, how many people out there might be doing credentialing right now. I know we didn't choose to do it. We did it in the old days to get it right. And then as our clients, you know, as we started having more and more problems, we started telling our clients, look, you know, this is great, but we're going to have to start charging you for this separately because it's really eating our lunch. We were having to hire people, keep up with the revalidations, and it's a much bigger process than it used to be in the old days. What are some of the pros? Well, the pros, if you do it as a billing company, usually you'll get it right if you know the process. The cons, well, it's a total pain. It really is. A lot of billing companies I know are outsourcing credentialing, or they're relying on their client to do the credentialing. So, just curious how many out there might be doing. So 92% are doing. That's great. That's interesting, because I'd be curious to know if you're charging for that, or if you just if you're rolling that into your fees. About 4 years ago, we started sending out notifications to our clients that we were going to separate that from the billing fees, and we were going to charge them separately. And only a small percentage of them decided that they didn't want us to do their credentialing. Most of them stayed with us. Good deal. Yeah, we actually tried to be a credentialing company, and we went out there for a lot of big events like MGMA and HFMA, and did a lot of advertising. But we found that we were a little ahead of the game, and most people don't want to pay for it. So trying to find a correct fee for this has been challenging. We did basically start on a flat fee, and then we went to a monthly fee, and now we're at an hourly rate. The hourly rate for us has seemed to work the best, because for clients that are established, that have been on board with within they've got their contracts, and they're really, revalidations is the main thing with them. We only charge them, when we need to work on their stuff. The hourly rate works really well. Obstacles for credentialing. We have clients in water cities like Miami and places that people want to move, and we have clients in Houston here. We have clients in Texas. We have clients in California, and a lot of times they're actually locked out of these. New clients coming in, or physicians coming out of school are locked out of these contracts a lot of times, and they call these panels, and what is a panel? The term panel refers to a specific area, and the amount of the contract slots available for that area, and usually by provider types. We found, especially in really areas like Los Angeles, that if we had a problem with a client not being able to get on a panel, or not being able to get into a slot, we usually try to get the physicians to join as a board of directors or something. It's very political, but it works in a lot of cases. Because really, what's going to happen is if there's oversaturation in an area, and you're trying to get a physician enrolled out in a certain area like Los Angeles, you're going to have to wait until that slot opens up, and that's the problem. Especially if it's a big contract in the area that pays 30-40% of the bills that come in. For hospital employees, and we've seen this a lot. The hospitals were gobbling up, physicians over and over in the last 5 years, and employing them. And of course, we lost some of those clients to hospitals, so you typically don't outsource their billing. But it's turning around again, and about 3 years later, 4 years later, we're seeing a lot of these physicians, especially in radiation oncology, being dumped back into the marketplace because they're basically, I guess the hospital contract with them wasn't lucrative enough, and they decided that they weren't making enough money on these particular physicians. So we're seeing a lot of new clients now that are coming back in. There's a big difference, though. Years ago, if they came back into the marketplace, it was just getting a few contracts signed and you're done. Nowadays, they're starting over. Their tax ID is not in effect anymore. They went with the hospital, and now they're going back in and starting another tax ID, and that tax ID is starting from scratch. So the whole process of credentialing is really time-consuming. We're now telling clients in this situation, and that would be also for clients, new physicians coming out of school, we're telling them a year by the time it's finished. And there's a lot of processes we're going to talk about in a few minutes, but there's so many delays now and so many issues that we're telling most of these people have a year's worth of income in your bank account. What's the provider enrollment steps? If you're doing this, which it looks like a lot of you are, you already know this is a repeat, but I'm going to go ahead and run through real quick. registration for an MPI, obviously, license applications and renewals, CAQH, which is important, provider enrollment payers, and then revalidation, which is required every 1 to 3 years. Timing, you know, a lot of questions about timing. How long does it take to do, the process? Because when people are trying to figure out what they should charge for it, they're trying to figure out how much time is going to be involved in it. And honestly, it depends. The process for a lot of physicians takes 90 to 120 days. TRICARE can take up to 180 days, but typically for us, we're about 60 days out. How many hours are involved in the application process? For us, it depends again, but we'd say roughly about 10 hours of work for a physician. Example, Blue Cross, about 4 hours, and Texas Medicaid, maybe about 6 hours. Medicaid has really been hard lately, especially in Texas. If you haven't run into problems with Medicaid recently, we're having a lot of issues with the new tax laws. We can't line up these new physicians with the enrollment process, and Medicaid's showing us it's got to be exact, except it can't be because they're not up to date with the taxes yet on their enrollment form. So it's been interesting. What do you need for enrollment? Again, we probably know this, but you need a license, obviously. You need diplomas. You need passport size photo, any kind of board certificates, obviously your federal controlled substance permits like DPS and DEA, and you need them to have a MPI confirmation. You get a lot of questions about CAQH, the Council for Affordable Quality Healthcare. This is a requirement. You must, start with CAQH. A lot of people ask, do I need to have an ID for CAQH? We say yes. Almost all insurance companies now require this to be credentialed. It's the first step of the enrollment process. It doesn't cost anything for us to enroll the physician under this. It costs the actual provider. The insurance company. Medicare is where we start usually as far as the first payer. It's probably the easiest and quickest to get up and running. Some of the things you'll have to be aware of is if you're doing corrections, you need PACOS. You'll need to get that access to that PACOS system. This is interesting. Prior to this came up with us recently. We had a new physician that joined the group in South Carolina. The physician was coming from a different organization, a different physician group. We were billing for him for about 2 years with this group, and all of a sudden we noticed in the reports we had Medicare outstanding past 30 or 45 days, which is unusual because Medicare usually pays in 22 days. So we started looking into this and found out that he'd been shut off from Medicare because his reval was not done. We never got a copy of that notice from Medicare because it went to the prior group that was doing his billing in the other group. So, this is some of the things you'll come up with. But what was different this time was, in the past, Medicare would pay as non-par for the time that spanned the time that the physician had lapsed. This time they went back to his 2013 enrollment date, but they refused to pay the month and a half that he was not enrolled in this process. And it was a lot of money for this one physician. It was about equal to $35,000 in lost income. So something to keep, if you are responsible for credentialing, which includes revalidations, there's a lot of liabilities legal here you need to be aware of. Make sure you write that into your contracts, and make sure you're aware that when you have a reval coming up that you're really on top of that, because you do not want to be responsible for lost income. You all know as billing companies that if you lose income for a client, they're going to come after you now. Medicaid, I talked about this a few minutes ago. It's one of the most complicated, payers to get enrollment these days. It's the longest. We have a lot of issues in different parts of the country getting some of our providers on Medicaid and Medi-Cal. Sometimes not, but sometimes we do. It's important that when you have a new physician, that you get all the details from the physician. And that includes any lawsuits they might have had before. We've had physicians come on and thought that wasn't important to tell us, and then it goes into a legal case with Medicaid for a year. So transparency with your docs is very important. IPAs are actually, we like IPAs because we have some new clients up in Chicago, and it's working out really well for us. The IPAs are helping us get into the marketplace up there with these physicians faster. If, for instance, if we have a group that works for a hospital up there, a pretty big hospital in Chicago, and that Chicago hospital belongs to an IPA, and we're actually required to go through IPA for a number of the contracts up there. And it really is a shortcut to get those contracts done. For a single specialty, especially radiation oncology, IPAs are really, really helpful for small physician groups as far as contract negotiations and getting on these contracts that I spoke about. IPAs, typically radiation oncology is, if there's 2 in a small town, that's a lot. In most hospitals, there's 2 to 4. That's very typical for the groups that we handle. We don't handle really big radiation oncology groups because they just don't exist for the most part. So, helping these guys get in touch with some of these payers, we found that IPAs are really, very, very useful for them. What are the top issues with credentialing? Well, one of them is changing tax IDs. We have had a number over the last 5 years of merger situations where we still were kept on doing the billing, but there's a tax ID change. That's important, especially it's nice to know before the tax ID change what's going on, because when you get that surprise, you're talking about 3 or 4 months worth of no income until that gets straightened out. If you have physicians that decide, groups that decide that they're just going to change their pay to address because they change their lockbox or their bank and don't tell you, that's another interesting surprise, and it'll cause a lot of problems because, again, you're going to be saddled with a bunch of work trying to get everything realigned with that lockbox or with that pay to address. And then that's a big credentialing issue. As we talked about before, misrevalidation issues. Not having the provider linked to the correct contract product type. We see that a lot. If you're not dealing with specialties, you don't have to worry about it too much, but we do deal with that quite a bit. I got a question here. Aren't revalidation dates publicly available?
John, let's unmute him and see. Maybe John can share with us.
Johnny there?
I am.
John, you want to share with us how you track your revalidation dates?
My understanding is that they're available up on a CMS site.
Okay, why don't you share, if you can find it while we're on the call, we can share it with everybody else. If you can find us the site, like the area on the site, we are on CMS, it's available, we'll share it with them. Awesome, thank you for that feedback, I appreciate it.
Sure.
I appreciate that. It'd be nice to know. Most of the time, we have a client coming on, we try to figure out what the validation date coming in is, and we mark it on a tickler system, so when it comes back through, we know, when we've got about 60 to 90 days before that to get the paperwork done. How to ID credential problems for billing companies, catching these issues fast is important. Again, if we have a new client coming on, we usually just run denial reports. We look for issues with certain denial codes that come back to the system that would tell us if there's an enrollment issue, and then we follow through from there. This is really important, especially for, like I said, new clients coming on board, because we're trying to figure out if there's authorization issues first, and if the credentialing problems right up the how to fix credentialing issues? Well, there's no magic bullet. One of it is just trial and error. But one of the things that we find is if there's a problem, check with the prior CBO or central billing office or the prior billing company, the client, and see if there's some issues. We have a lot of times that clients come through to us and they're still tagged to the old billing service or the old group. And there's been a problem trying to get this fixed. Sometimes it's trial and error with the payers. For the new physicians, you need to have a prior transaction access number for that COH and the CAQH logins. Any way you can get in there, make sure that stuff is corrected is important. Common credentialing mistakes: not keeping up with the CAQH database updates, not obtaining up-to-date documents from your physicians, like board certificates and CVs, et cetera, insurance. Disorganized credentialing information files. We've taken on clients that have sent us boxes of paper. Honestly, it's that's how they did their credentialing, and there's a lot of technology you can use now to keep track of your credentialing and keep it organized. Errors on applications. A lot of times that when you send an application, there's a small error on it's going to come back. I'm not going to necessarily tell you what all the errors are on that one application. It's just going to tell you the first one. You send it back and hopefully it goes through. Not having realistic turnaround times. As I mentioned, we're telling clients now that, you must be prepared for credentialing issues. It just depends what part of the country, but, in the best of all worlds, maybe 45 to 60, 90 days, worst up to 10 months to a year. So software solutions, we've used a number of different software. The problem we had in the past was because we're running across state lines, there were a lot of differences in credentialing in different areas of the country. So we actually use spreadsheets for a long time, track a lot of our credentialing. We did use Vistar for quite a bit. It was okay. It's a good program. There's another one I just was looking into. That's a solution by CAQH. Again, it's just trial and error, and a lot of times you get a free software trial to look at the software when you're deciding what's the best. The pros and cons of software solutions. This is what we found from using software versus spreadsheets. The application process to set up can be great. As far as it can be completed electronically, and it's a lot. It's not. For us, it's easier to access. The con requires a lot more hours of training to get that software up and running. And the biggest issue is for us, if you've got a lot of spreadsheets with tons of information on them, getting that in there's if you can't interface, it's going to be data entry hours for someone to get that in. From the pros, applications can be automated. And one of the cons, most providers are switching to online applications that don't require software. Again, that's something we use also. Pros, once the data in the program is easier to locate, true. Cons, takes a long time to get it in there, as I just mentioned, software. Pros, clients can access their data anywhere, and enrollment process is on time. Now, if you have clients that are trying to get up and they're getting anxious about when they can start billing, they're holding their charges on certain payers, if you have a process in place or software that they can access, it's great because they can look it up and see where the process is. Even with spreadsheets, we've used secure FTP servers, and we give access to our clients so they can get up there and look at that particular, where they are in that particular situation with credentialing. One of the things that obviously that spreadsheets won't do is they won't automate the process as far as sending out emails to clients on a weekly or monthly basis, giving them updates about what's happening with their credentialing. Another pro, application can be located in the software and updated automatically by the vendor. Cons, there are too many insurance companies apps. This is a problem we ran into across state lines, which is too many different forms out there to keep track of. Last pro in credentialing, the app forms can be made into templates. In certain states, the credentialing templates can be turned into the application can be turned into templates. The cons, in some states, nationwide billing services, for instance, no standardization for insurance. So I just mentioned it's one of the problems we ran into a lot. We use spreadsheets. They're pretty complicated spreadsheets, but they work for us. We've gone back and forth with software. We still have a very organized method for keeping track of this, and it works for us. It just depends on what's best for you. That's just an example of spreadsheet. I can't see it. It's if you want to email me, my email address is on this presentation, and I'll be more than happy to send you this very generic form that you can use for whatever.
We also sent in the chat, you sent out a message. If you're using the credentialing software that you like, you could enter it in the chat box so you can share it with everybody.
Yeah, that would be good. I'd be curious if you're using credentialing software, one thing I'd be curious is, are you regional? Are you in one area? And if so, what are you using? If not, I'd be curious what you're using also, because as stated, the biggest problem we had was crossing all these different areas across the country with non-standardization forms. It was turning into a monster job trying to keep up with it, and it was just easier for us to deal with online applications and spreadsheets for tracking. Authorizations. Be curious, as we did with credentialing, Cheney's going to ask you how many people out there are doing your own authorizations. I know, for a lot of our clients in radiation oncology, they're usually, and I would say 60, 70% of the cases, they are 2 to 4 physicians going into a hospital. They're a separate group. They have privileges to treat there. Maybe they're treating in a couple of hospitals, and they're dependent on the facility to get the authorization. So that's what we're finding mostly. Okay, well, that's good. 42% of you voted, and it was a 50-50. We do provide authorizations for clients that are kind of standalone clients. Let's say one doc physician for radiation oncology that just has no employees. So we will do the authorizations, but in cases where they're working in a hospital, we are dependent on the hospital a lot of times to get that authorization. We'll talk a little bit about that as we go into this. As I just stated, about 8 times out of 10, we found that that the authorization is done for the billing company. Getting the authorization for us is very time consuming when we're doing it. And it is also for a lot of our clients, in the hospitals with our clients treat at, it's become very, very picky. It comes right down to the CPT codes and the diagnosis. And for radiation oncology, there's some unique codes. It's a high dollar, service. So the reimbursements are high, and getting authorizations, it can be tricky. But there's, as the influx of managed care gets more and more, we're finding that, the authorization process is very, very important. This is just a study from Dana-Farber Cancer Center up in Boston. It's on 2007. It was a study of 1,000 patients, and they found that, medical practices completed approximately 29 prior authorizations per physician weekly and took an average of 16 hours of physician's time. More than 90% of the physicians reported care delays, and 78 reported that prior authorizations led to treatment plan abandonments and other issues. And this is oncology, medical and radiation oncology we're talking about mostly. And we're seeing a lot of peer-to-peer with physicians, with insurance companies to get authorization. So when you see 16 hours, this is probably the reason why of time per week. We have a lot of physicians that spend almost one day of the week just taking care of authorization issues and their documentation issues. And they're busy people, so it's hard for them. We've seen patients abandon because when the authorization wasn't approved, abandon the treatment. We've seen issues with drug therapies, especially with expensive drug therapies. It's very irritating for the physicians, but I was at HFMA yesterday listening to some talks about different payer models coming down the pike and getting paid for getting paid according to how well your patients do as far under your care. It's very interesting where we're going here. And the coding and all this stuff and authorizations is getting more and more important. Delays in authorizations. We see it all the time. We have situations where, the delays will cause issues as far as when we get the bill out the door, if we're holding charges, usually we don't run into time in filing deadlines. Usually that's not the case. We do have some providers that have to provide, emergency cases that have to be done the same day. But we usually tell a lot of the people that we are doing authorizations, the clients we are doing authorizations, we usually tell them we need about 48 to 72 hours. In our contracts, we write 72 hours in. It causes a lot of flack sometimes for physicians that are going between facilities for coverage, but we can't control the insurance companies in that timing. As I said, 72 hours is probably a reasonable time frame if you're doing that for your when we're depending on the hospital, a lot of times that's what we're dependent on there too, about that time frame. Normally, maybe 48 hours, 2 to 4 days is usually when we get that authorization. And the patient, now, radiation oncology is a little different when a patient comes in, for instance, a patient comes in and gets a procedure done. And radiation is ongoing treatment, so the patient comes in for consult, and the planning is done, and the patient's treated for anywhere from 5 to 48 fractions, which is anywhere from a week to 6 weeks. So this is ongoing treatment. Managed care plans, which payers should be authorized? Obviously, any managed care plans, any HMO plans, any managed care plans. If you're dealing with a hospital situation where the patient's coming in, a lot of older patients for cancer care, and they have Medicare, be careful, because a lot of people are switching to managed care plans today, and those hospitals a lot of times don't think those plans need to be authorized, and they do, just like any Medicare plan. Does your EMR have the ability to hold claims that are not marked or authorized, approved? We do. We use all scripts, and we will not send anything out the door that we know is supposed to be authorized that has not been authorized, because as many of you are aware of, we don't want to deal with rejections on the back end. Trying to get it done correctly the first time is important. And I know for a lot of billing companies, you're dealing with a lot of authorization denials. Even if you're dependent on the facility and it gets authorized, it doesn't necessarily get paid. There's always other issues that come up too. And this is where hospital employed physicians may come into, these guys, that if they're not employed by the hospital, if they're employed by the hospital, it's different. But if they're not employed by the hospital, like a lot of our clients aren't, trying to convince the staff there to do the authorization sometimes is interesting. But what works for us is incident to. And that means the radiation oncology is incident to, which means it dictates everything downstream. So when the physician comes in, not only is he responsible for his charges, but he's responsible for the charges of the technical side, the hospital side too. So when they say they're not going to help, with the authorization because he's not an employee, they need to understand it has to be done because that person is responsible for their charges too. And usually, when we use that angle, it usually does not present a problem. We also help the staff there. We'll provide them with cheat sheets, for different procedures that are done, different diagnoses for cancer, and what codes they have to authorize when they get on the phone with the insurance company. This is an example of a cheat sheet we use. Again, it's got certain codes that are most widely used for certain treatments: radiation oncology, 3D, radiation oncology, IMRT, intense modulated radiation therapy. Those codes are on the sheet right here. And, a lot of times we will coach the people on which codes to get approved when they get on the phone with the insurance company. And it gets right down into the fractions. And when I'm talking about a fraction is how many treatments the patient will have. We have a process called a boost in radiation oncology where the patient may be treated for 4 weeks and then the tumor shrinks and the physician changes the plan and boosts the treatment as far as the amount of grays to the patient, but it's changing that beam to a smaller beam to account for the size of the smaller tumor. And it's important that the physician tells someone or the staff tells someone in the front office that that's being done, because what we see now is a lot of denials because the process is done, another 6 treatments, and the patient leaves, and then the insurance company denies it because it was not authorized. Payer guidelines, we get a lot of questions, which payer guidelines should we stick to? It just, obviously CMS is one, but, we're telling a lot of our physicians that are fighting payer guidelines by Blue Cross, EvaCore, all these different people, that it's going to be harder and harder. There's a new process in Canada called fractionated radiation therapy, which is more higher dose of radiation but less treatments. And it's catching on, and insurance companies like it because it's less money they have to pay. So, if we always advise a lot of our clients to have policies about the protocols for treating, and if the physician insists that they have a better way of treating the patient, then that's fine as long as they're willing to fight. We're going to talk and give an example of that in some future slides here that's interesting. Medical records. Medical records is important. If you're not charging for medical records, you probably should be. because of the high dollar on these claims, we get a lot of requests for medical records, sometimes up front. For VA, we already know that once we get an approval for VA, we just send the medical records for the treatment because we know they're going to ask for them anyways. So, there's a lot of ways to do it. I'm not going to get into the logistics of that, but, we do charge for that service. This is an auth example, and again, this is a lady who came in for a skin cancer around her eye, and the physician, Dr. Regardless, is somebody I'm familiar with because I worked with him for a number of years doing talks. He created all the CPT codes originally for radiation oncology. He's 86 years old, still smart as a tack, and still treating 50 patients a day sometimes, which is pretty remarkable. But this is an example he gave. He had a patient that he wanted to treat with IMRT that had a tumor in the back of her eye, and she also had skin cancer. And the protocols, for this particular, I think it was Aetna, would only pay for 3D. So here's the patient right here. As you can see, the tumor is on the left of the eyeball. It's actually on the right, I'm sorry. And, if you look, radiation, I'm not going to get into how radiation works, but radiation will go through anything to get to the tumor. So if you point it through the eyeball, it's going to blind the patient. So they were looking for different ways to treat this patient with the least amount of scatter from the radiation oncology, from the radiation therapy. This is the Aetna IMRT policy. I'm not going to read it to you, but it's basically saying what they'll pay for radiation therapy. You can read this when you get a chance. Here, you can look at these three pictures. There's a acceptable, which is the 3D plan. There's better, which is an ARC plan, which I won't talk about. And there's IMRT, which is a 5-port step and shoot procedure. Now, what you're looking at is the color there that's lit, like it's like a light, like a blue or some purpley. That color is the scatter from radiation oncology. As you can see on the right, by shooting that angle and using IMRT, the patient gets hardly any dose to the brain and very little to the eyeball. Now, if you go back and you look at what they'll pay for IMRT, in this particular case, they're only going to pay for 3D because they say 3D is effective according to what they've seen. Well, the doctor made a case here that no, actually the better treatment was IMRT plan. Well, here's the difference. 3D, a course of treatment probably is about, for global, it's probably about 21K reimbursement. For IMRT, about 48,000. So, why did they want to do 3D? Well, because it's cheaper. It's a lot cheaper to pay. And, and Dr. Bogardus was able to track that and be able to prove to the insurance company that actually this was a better, and he got it paid, and they actually approved it. But it was a lot of work. It was a lot of peer-to-peer on the phone with another physician who was a radiation oncologist, and a lot of times what we have to do in radiation oncology is when we have these kind of situations, another example is breast cancer. A woman comes in, she has left breast cancer, close proximity to the heart. They're going to pay for 3D because that's the standard care plan, but IMRT is much better and will have much less toxicity and probably no damage to the heart muscle. But you have to get on the phone with the insurance company and you have to send the plans into them. This is why it takes long to get. For us, it could take 72 hours to have an approval because we send the plans to the insurance company, they have to be reviewed, and we have to make the case that this is better treatment and this is how we get paid. So as you can see, things have changed in recent years and it's a lot more complicated to get these done now. As I say, the devil's in the details. It really is. If we have a patient coming in for a certain type of treatment in a facility, we will tell the front office which codes to get authorized. And sometimes we'll tell them there are a lot of other codes that maybe aren't exactly, the codes that, they'll get treated, but we'd rather be safe than sorry. Templates for authorization, won't go into this. I mean, honestly, what we're talking about here is any kind of thing you get on the phone, talk to an insurance company, what kind of template you use. We looked at kind of a cheat sheet before. This is okay. A lot of the EMRs now are actually helping with this, and you can actually build templates for them to do the same thing. This is EvaCore. EvaCore, this is an example of breast care patient right here. I took the information out, obviously, but this is required now for Blue Cross, and it's a breast patient, and they have them for breast, prostate, lung cancer, all different cancers, and you're required to fill these out and send them in. They're very, very technical forms to fill out. Who should do authorizations? Well, We have people in our office that are clinical that do these, and it works out really well. We tell our staff in these different offices, clinical people are better because nurses, social workers, anybody that's dealt with that treatment understands when they get on the phone, the insurance company they're dealing with. Problem is hospitals don't want to pay for it. That's great. Hospitals don't want to pay for it because it's not cost effective. They say, well, two unauthorized IMRT treatments is over $80,000 lost income. That well pays for that one person a year. So if you can convince the hospital to hire up on that, it's very worth it. Tracking authorizations, again, we're not going to get into this too much because we're running out of time here, but we use a combination of things. We use an FTP server with Excel, so our staff can get up there and find out, if we're doing authorization. Their staff can look at where we are in the process. We also have a tickler system that works too. We can send out emails, but for the most part, it's on the phone, calling the facility, calling them, and asking them and telling them what's going on. VA, especially in Texas, some interesting things. Again, VA, usually the patient, we don't typically authorize VA patients because they come to the facility with a form already in the primary care from the VA. From there, the facility authorizes it. Just be careful when you're dealing with the VA. They're good at changing stuff, but once you authorize something, an example would be we had a patient in the cancer center that was authorized for radiation therapy, went to the hospital for a report, was concurrent chemo, and the hospital went ahead and authorized the chemo port, which then took down the authorization for the radiation oncology. So we were back to ground zero doing the whole auth over for the radiation. Took another week to get that approved. The good part about about VA is usually if you make a mistake, if you can get someone on the phone, they'll correct it on their side. Session bullets, if you decide to do credentialing for your clients, know what you're getting into. If you're adding a new client from scratch, new tax ID, be specific, be honest with them, prepare for charge either upfront fees per click. If you know that patient, that insurance, that provider is going to be in a situation where they're not going to have income in a while and you're doing percentage billing, you need to get paid. Either that or charge an upfront fee. Session bullets with any client, pay special attention. The first 90 days, run reports for any denials. Be aware of IPAs as fast tracking. Have a written agreement and contracts and how you'll get paid for the client from their tax ID. First name and address, bank accounts, all that kind of stuff. You need all that information. If you are doing credentialing, use a system that works and keeps you organized. Please, no boxes of paper. If you rely on someone else to do the authorizations, monitor for denial, especially with new clients denials, use lost payments as a way to persuade clients to fix this problem if they're not listening to you. Help your hospitals, clients by working with their staff as far as like sheets and things like that. Know the payers need authorization and make your billing software hold those claims if necessary before submitting them. Have your protocols in place for how you're going to treat your patient. Use technology to track your authorization process. Hire clinical people for your authorizations. And, if that doesn't work, get someone who's knowledgeable about that particular type of treatment. All right. I think we got out of here in time. I appreciate it. Thank you.
Awesome. Really, really great. Okay. Dave, you're with us?
Yes, I am.
I unmuted him. Hold on. Dave, could you hear me?
Yeah, I can hear you. I'm here.
Hey, how are you? Okay, tell us a little bit about your conference, and then if anybody has any questions, you can put that in the chat box. Okay, Dave, tell us what this is. We have Dave Jekyll on the line, who is running the Medical Billing Executive Conference, right? Did I say that right?
That's correct.
Okay, and I'll be there. Kevin will be there. Josh may be there. Dave, tell us what we could expect.
Well, this is the 25th year of the conference. It was formerly known as the Owners and Managers Conference, but the name's been changed to keep up with the times here. It's the Medical Billing Executive Conference. We'll be holding it February 18th to 20th in New Orleans. And this, again, is our silver anniversary, our 25th year. And some of the highlights will be the topics we put in these sessions are based upon our clients and what we see on message boards, et cetera, as to what's important. So We'll be talking, of course, about marketing strategies because marketing is the lifeblood of our industry, basically, as things consolidate in the industry. We get a lot of questions on how do I get to the next level? People will say, I've been stuck at 15 employees or 30 employees or 50 employees, and I want to get to the next level. So there's actually two sessions that sort of deal with that. One, it's how do you get to the next level? And the other one is about operations. And what we'll do is my co-presenter, Bob Burley, and I will be sharing with you, because we work with dozens of companies all over the country. Well, we're going to do a sort of a report card of what a freshman company looks like, what a sophomore, junior, senior, and a PhD. Obviously, the PhDs are the larger companies and how they got there. So it'll just be a roadmap if you decide that, yes, I do want to get to the next level. Of course, we'll be sharing benchmarks that we see in companies, and these have been changing as technology is getting embraced by the operations. So that's only a few. If you want to check out the entire conference, please just go to the website. It'll give you the presenters. It'll give you the topic descriptions. You can find that at www.mbec.biz, B-I-Z. And any questions, my email's right on there. Just send me an email, and look forward to seeing Kevin and Janie and some of you who are also on the call. See you next week in New Orleans.
Thank you, Dave. We're looking forward to it. I put the website link in the chat box for anyone that wants to see more information. Thank you, everybody, for joining. We have a couple minutes left, but if there are any questions, please send that out. If not, which I don't see any questions yet. Oh, I do here. Let's just take a quick look. We'll give everybody a moment. If you guys have any credentialing or authorization things you want to talk about. If not, you could always email Kevin. That's his email address. It's on the screen. And hold on. Okay, let's take a look at that. Okay, I think we are good for now. We'll see you all on March 14th at our next mastermind in Scottsdale next time. If you'd like to host a mastermind in your city, please let us know. Okay, thank you, everybody. Have a great rest of the day.
Take care. Take care.